Can I get a second?
Second.
All in favor?
Aye.
Any opposed? Okay, minutes approved.
Cynthia, was there any public comment?
No, there was not.
Okay.
Great, thank you, Cynthia. And next on the agenda is Michelle to give the executive director update.
Thank you very much. And again, board members, if you are joining us, would you please put your cameras on for the meeting? Thank you. So just a couple of federal updates that we have. As we continue to see, all eyes are on the public health emergency unwinding. The good news is Maryland is doing well in that regard compared to other states, and myself, when I'm talking to my counterparts at the state-based exchanges, our operations and our collaboration among departments is much better. So although we know we have a lot more work to do, and you can all encourage everyone you know to make sure they're paying attention to their notices, updating their information. But we really are working hard to make sure that nobody loses health coverage during this time. The other bit of exciting federal news, our 1332 state reinsurance waiver was approved by CMS for an extension for another 5 years. So that will take us through 2028, which is great. And that was extended on June 28th of this year, which was pretty swift in terms of getting a response back. We're happy for that. There's not a lot going on coming out of Congress right now. Everyone's gearing up for their summer recess, and so things have been quite quiet there. Nothing to report. For our state updates, of course, I think everyone by now is aware that the individual and small group market proposed rates have been released. The good news on that front is that the proposed rates are actually less than what the actual rates were last year. So the average proposed rate is an increase of 5.7%. And remember, this is just proposed before the Maryland Insurance Administration does their work on reviewing. And for the small group rate, it was on average 7.5%. Public hearing will be held this Wednesday, July 19th from 10 a.m. to noon. So anyone who has an interest in listening in or making comment on the proposed rates, we encourage you to do so. And you can visit the Maryland Insurance Administration website to register for that. Another ongoing initiative is, which came out of the 2022 legislative session, House Bill 413, which requires the MIA in consultation with the exchange and with the MHCC to report to the governor and the General Assembly on the impact of the state reinsurance program. The report requires consideration of whether the level of funding is appropriate and taking into account things such as the future population growth and projected premium growth. The legislature also wants to know whether the assessment is appropriately apportioned among the carriers. They want feedback on that. If it should be broadened to include other business sectors, and should it be supplemented with general funds? So that's all part of the consideration report. Also, they're interested in learning more, about what market reforms are needed to provide affordable health coverage in the individual market. Whether it's continuation of the reinsurance program, providing state-based premium subsidies, or expanding eligibility for Maryland medical assistance through the program. And then also another area they're interested in is the design of the program, including program parameters in light of the young adult subsidy program we have ongoing, the easy enrollment health insurance program, the special enrollment periods what we put in place, and the premium subsidies that are currently affordable under the American Rescue Plan. So that's been ongoing since the spring with the agencies meeting and gathering information. There has been one public hearing and possibly two. There might have been two. The next public hearing is scheduled for Friday, August 4th from 10 a.m. to 1 p.m. And again, we encourage everyone to participate. Your voices are important to us as the work group puts us together, and we encourage you to join. You can again go to the Maryland Insurance Administration website to register for that. The board and senior leadership of the exchange held a planning day on June the 3rd, Tuesday of June. And it was a really excellent session where we looked at what's coming before us, where we've been, and had some wonderful panels of consumer sister groups come in and really provide us with good information on looking where we move forward. So that was a good session. Part of what came out of that is a little shift, not much, in how we operate our board meetings. So we will be going from 9 board meetings a year to 8 board meetings a year, and we'll alternate, one totally virtual and the next in person. So give us a little bit of a balance, accommodating the new hybrid world that we are working under. And during that planning session, we did have a discussion about the board leadership, or the carriers achieving health equity accreditation, which came out of the health equity work group that the exchange held last year. And so part of that was making sure that all of our carriers that participate on the exchange get certified with this accreditation. We did follow up and did learn from NCQA that CareFirst is currently in the process. Their survey is scheduled for November 7th. Kaiser has a survey scheduled for October 15th of 2024. And United Healthcare was not yet scheduled, but NCQA would be following up on that. So again, just a really great outcome of the health equity work group that the exchange had in place last year, being able to translate that information, provide it to the board, and having this again a focus for our carriers on the exchange to make sure we're addressing health equity needs. And just finally, we added to the MarylandHBE.com website an interactive enrollment dashboard. And this, I encourage everyone to go take a look at it. Not only does it have the consistent data that we've continued to share for many years now, but it also has new interactive capability where you can drill down into a particular region. We will be adding legislative districts onto that by House and by Senate. So that will be another useful metric that we can use, but I encourage you to go look at that. And those are my only updates for this month. Secretary Herrera Scott, if there's any questions, I'm happy to answer them.
Any questions for Michelle? Okay, thank you, Michelle. Next on the agenda is to hear from Dana on the Standing Advisory Committee report.
Thank you, Chair Scott. The Standing Advisory Committee met virtually on July 13th. In addition to the usual warm welcome by the co-chair, Don Frank, and the executive update by our very own Michelle Eberly, other agenda items were, I gave a brief summary of a few key relevant topics that both the board and the staff members share that were covered in the Board Leadership Planning Committee on June 20th. The agenda also included MHBE 2021 Work Health Group updates, MHBE Work Group recommendation on consumer decision support, an update on the unwinding of the Medicaid public health emergency by Alyssa Brown, Director of Innovation, Research and Development in the MDH Office of Healthcare Financing, and by our own Joanna Fabian Marks. We heard about proposed regulation changes in 2024 plan certification standards. I'll cover just the work group specific items with a few details. Otherwise, I'll talk too long. Our own senior policy analyst, Becca Lane, updated the Standing Advisory Committee on Issues and Work for the Health Equity Group. And her presentation consists of informative and rich in detail updates on steps MHB has taken to improve the quality and quantity of race and ethnicity data as per recommendations of the 2021 Health Equity Work Group. Before I move on, I would like to suggest this presentation and the update she may have be added to the board agenda at some point in the future. It was a great presentation with lots of great details. Some of the key highlights are enrollment trends. Let's see, have the exchange track progress towards health equity goals, set its targets, informs outreach and media campaigns. So that was great. In April 2020, MHBE launched the updated race and ethnicity questions that it worked on. And those were questions which were aligned with best practices at the time. And the news, improvements in the response rate occurred. And also consumer assistance worker training was also conducted. Our policy analyst, Amelia Marcus, reported on the interest in convening a work group to discuss current and continuing consumer needs and challenges when shopping for and choosing a plan. And as we remember at our planning meeting, that was discussed too. The SAC members were in support of this and the steps that have been taken thus far. And I would also like to suggest that this be an agenda item at some point in the future. Thus far, MHBE has had the Hilltop Institute did a literature review focusing on articles that examine decision aids used by websites of state, federal, private insurance groups, and the marketplace, and did experiments to determine the efficacy of specific decision aids. MHBE staff reviewed it and tested 15 state-based marketplace web platforms and their consumer plan shopping tools. And some highlighted tools were additional questions and guided information that we didn't have or don't have, guiding pop-ups and rollover information, default sorting and filter options, plan information display, for example, lowest expense, highest expense for a plan, cost estimates, nearby physicians, etc. And that's pretty much it. Do you have any questions or you would like the details? Please let us know.
Any questions for Dana? Okay, thank you, Dana, for the update. Appreciate it.
You're welcome.
Next on the agenda, we're going to hear from Tony Armiger, the CFO, regarding procurement presentation.
Good afternoon, everybody. Cynthia, do you want to show the slides or do you want me to show them? Thank you. Okay, let me close this thing here. Okay, go ahead to the next one, please. Okay, so Maryland Health Benefits Board procurement approval process. I'll just explain a little bit about that. MHB's procurement policies and procedures. The policy is a formal document that lists all requirements of the board and staff for procurement processing. The policy does not identify when multiple year procurement should be brought before the board for approval and when the board would like to review the procurement before its effective date. So this procurement policy is out on the website, MHBE, and I'm sure everyone knows that, but all procurements requiring board approval should be presented to the board according to a specified timeline and in a consistent format to allow board members ample time and materials to make sound judgment and decision on potential contracts. And that's all listed in the procurement policies. Currently, the board must approve all contracts in the amount of $200,000 or greater. And the value of the contract, by the way, is the base years plus option years. multi-year contracts are often entered into and approved by the board. Monthly and annually, all contracts are reported to the board. So every month you get that contracts list that we send out to you, and at the end of the year, and every month it has the additional contracts highlighted in yellow along with the prior month's contracts. Okay. So this is where we're talking about a potential current process and the proposed process. The current process for base years, I'll take, for example, our call center. Currently, we preview to board 30 days prior to presenting award for board approval. The board approves base year and option years for a full contract period. So the board approves the whole contract. And the board approves a not to exceed amount, an NTE, for 1 year only. And that's the current fiscal year, well, the next fiscal year, because we usually present this to you. Well, it could be the current fiscal year. For the call center, we usually present to you in April, May. And so basically the NTE the board is approving is the following fiscal year. So a purchase order or a blanket purchase order is created for 1 year only, and it's the current system. Annual presentation and approval by the board for additional base years. So base year one, which we enter in the new contract, excuse me, we come to the board with the whole contract. For instance, the call center was 3 base years plus 2 option years. The board approves the total contract value. And then each year, we also approve the amount for the board for that 1 year. So basically, for instance, this past year, we only came, even though we approved the total contract value in before FY 23, we also came to the board for FY 24 total to approve the base year 2. The annual amount for the contract is included in the budget approved by the government and the legislature. The way that other agencies do it, and this is a recommendation, so proposed processes, the recommended award is presented to the board 60 days prior before contract effective date. The board approves the base year and option years for full contract period not to exceed amount. A blanket purchase order for the entire contract value. So in the call center, it would be 5 years because it's 3 base years and 2 option years. A purchase order will be created for each base year. And what this would do, we want to eliminate, and this is of course certainly up to you, and we want to eliminate the annual presentation approval for additional base years. So in the proposed, and this is, I think this might have been recommended by a few of the board members. So in the current, the main difference is in the base current process, we would come to the board for base year number 2. In the proposed process, base year number 2, we would not have to come to the board because the board already approved the base years. And that's the way BPW does it also. And so likewise, the annual amount for the contract is included in the budget approved by the governor and the legislature. So that's the base years. Are there any questions as far as the differences between there's really only one with the base year, and that's coming to the board every year for each base year, as opposed to coming to the board, the current process, which is the proposed process, which is coming to the board once for the original inception, and including all 3 base years are going to be approved by the board. Does anyone have any questions about the base years?
Just one question. So when you said base years, you mean the renewal years after the base year? So there's a base year, meaning the first year, and then after that, or the base period of the contract, which may be a 3-year contract, and then 2 annual renewals. So when you're saying the terminology base year on a 5-year contract, the base year meant also the renewal terms, correct? Or
I believe the renewals are only in option years. We're going to renew the option year. So the base year, technically, it's a base year, so we do not have to send out a renewal. It's courtesy. I mean, some carriers would, some vendors would like that. But basically, for instance, the call center, the base year is 3 years. So since the contract is for 3 base years, technically, we don't have to send out a renewal for base year 2 and base year 3.
so option period rather than an option, I mean, the base period rather than a base year, because if it's 3-year, then the 3 years is the period of the base. And in this proposed process, will the board have to be asked for approval for the option years? Or will the board not have to be asked for the option years?
The option years is on the next slide.
Okay, the other question I had was, because the budget is determined each year, and we do not know from year to year what the budget will be next year. And if some of these contracts are approved at a certain level, and if there's a budget reduction that was to be proposed, what happens in that situation? Do we have the ability to go back and renegotiate those contracts because the funding has been reduced?
Well, I don't necessarily think, because the funding was reduced, I don't necessarily think that a vendor would lower its prices because of decreased funding. That's what we could try, but I don't think we would be very successful at it.
I know in other many other jurisdictions, there's a clause in the contracts that it's subject, the annual renewal is subject to receiving funds in the budget. Do we have that clause in our contract?
And I believe we do.
Yes, all of our contracts have in there subject to availability of funds.
Great, so that covers us there. Then my question gets answered by that. Thank you.
Okay.
Yes, can I make a suggestion and or ask for clarification? In the
Sure.
second bullet point under proposed process, to me, it would make more sense, or I'd feel more comfortable based on what I heard, that it says board approves base year paren as other paren. So it'd be base year years, because not all of our awards are 1 year base.
Yes, ma'am.
And just to clarify that a little bit, internally, we use the term a base year or years, meaning the base period for that
Period.
contract.
It's a period.
So it's
yeah.
a period, it's a base period for that contract. And then, so nothing changes in that base periods, as long as we have available funding for that.
Then I
Beyond,
would say, go ahead.
beyond that becomes the option years, where
Gotcha.
then we exercise the option to continue the contract.
Okay, I like period better then, because it covers year and years. Not that it makes any difference at this point, just so we understand what it means.
That's right. Okay, thank you. That's good input. I will make that change. Does any other questions for the base? Okay, Cynthia, can you, thank you. These are the option years. The option years are presented to the board at a minimum 30 days before contract renewal. The board approves the option year not to exceed amount. This is the current process. The purchase orders created for the option year. The annual amount for contractors, including the budget approved by the governor and appropriated by the legislature. The proposed process. Proposal for board to exercise option year contract is presented to board 30 days before contract renewal. Board authorizes staff to exercise option year. The purchase orders created for the option year. And then the amount also is approved by the governor and the legislature. This is pretty much the way it is right now. For option years, the way BPW works is each option year is taken to BPW and approved by BPW. So that's basically the proposal. And for option years, we still need to get board approval to exercise the option years. Anybody have any questions?
For clarification, if you need more money for whatever reason in NTE, anytime during this process, the NTE would be covered the first time we approved, and if you need at any point more NTE, you would come to us, even though it doesn't say anything on the right-hand side. Am I correct?
Right, you're exactly right. So basically, anytime we have an NTE increase, the board only approved the NTE amount. If it goes above and beyond the NTE amount, the board also has to approve.
Thank
Okay,
you.
you're welcome. Any other questions?
So I
Okay,
think I understand the difference here would be as long as you're within the NTE for your exercise option, the staff would be authorized to just go ahead and exercise that option. And you would only come back to us if, as Dana just indicated, the option would require a higher amount, which to me makes perfect sense. But is that the delta? That's the difference?
well, no, personally, I mean, you have your option. That is an option. Or the option is for option years to come before the board and get approval for option years. The way BPW does it is the option years are approved by the Board of Public Works for each option year. So that is an option, and we're going to get into some questions here how you guys want to proceed. But so here you're right. There are two options. The 1 year is we could do it the way the state does it, well, BPW does it, and for option years, we come before the board, and the board also has to approve.
So
The
I'm
second-
struggling to understand, and I might be having a dense day issue here, right? I'm struggling to understand the difference between the current process and the proposed process. What's different between those two?
Well, for this proposed process, there really is no difference. But the option years, we come before the board every year. If there's 3 base years, we come to the board for approval for all 3 base years. If there's 2 option years, we come to the board for each option year. So that's the same for option years, it's the same.
So
But
you're not proposing to change anything.
I
right,
think the one difference, Tony, was that because the board, when they approved the the contract amount for the base period and the option years. So they approved that contract amount for that entire period. So the nuance here was that we would not need to come back for the NTE amount, but we would come back to have the board say, yes, we want to exercise that authority to do the option year. And it also gives staff a point in time where we can report to you on, a structured point in time where we can report to you on, here's how the base period went. And this is why we think the board should exercise the option into another contract period.
Thank you.
Michelle, but doing it the way you're doing it, wouldn't we lose that? Like, so by after the base year, when you come back for the option years, whether you're exceeding the NTE or not exceeding the NTE, the expectation is that the base years went well, which is why you're approving the option years, but you would still give the board some update of that, correct?
Exactly. Give the board an update, and the board has the board can either exercise that right to do the option year or not. And so you don't really need to approve the NTE because you did that when you did the base period and the option years, but you don't, because you approved the NTE way back when, doesn't mean you have to exercise that option year.
So just to follow up on Kathleen's comments, right? Because the language is finessed a little, but I'm not sure if I'm hearing the same thing. So are you saying that you wouldn't come back to the board to exercise those option years?
No, we would, absolutely would. We would come back to the board for all option years.
Okay,
This language doesn't feel that way. That you will come back to the board for the option years.
That's the intent, correct, Tony?
Yeah, so basically, yeah, so the intent, as I see it here, we have one of two options. Option years, options. The first option is to continue to process as it currently stands and come to the board to exercise the option year. And when we exercise that option year, I'm sure the NTE would be displayed too. The other option is that once you approve the contract at the very beginning, you can say the base plus the option years have been approved by the board. Therefore, we don't need to see the option years. We don't need to approve the option year because we originally approved the contract for the option years.
And I suppose, if I may, that this is all for the same level of services. If the board was to approve a contract for $20 million and it is to answer 200,000 calls, as an example, and we say, well, the NTE is $20 million, but somehow now we will only have the vendor answer 180,000 calls. That changes the relationship between services to be purchased, and even though the amount is same, that will come back to the board in that scenario, something like that, because we changed the level of services we are buying.
Right.
Do we agree, or is the amount supersedes everything else regardless of the level of services being purchased?
Well, I guess we would have to do a modification if there are additional services that needed to be purchased. As far as a decrease in the amount, like whether you're in your case, 200,000 calls, that's in the option year contract, and it looks like it's only going to be 180,000 calls. We certainly could come back to you for the price of 180,000 calls, or we can come back to you with 200,000 calls. So that's I think that's pretty much your option, what the board would like.
You could, or you would.
So typically, I'll just interject here. So when the board approves a contract, all the terms of that contract are specified. I mean, it's all laid out of what we will cover and what the price, the NTE is a not to exceed amount. But we will say, this is what we're covering. So in the what example you just gave, saying call center, we give an NTE. What's laid out in the contract is you have to answer calls within this service level. We don't specify you have to answer 200,000 calls. That would be within the NTE. Here's how much we're going to pay you per call, but that's the not to exceed amount. So if there's a change in either the not to exceed amount that we've approved, that the board has approved, or in the services rendered by the contract that the board has approved, then staff have to bring that back to the board for approval. We have to make sure, there's some if the price increases, we can do some modifications, but if that modification is going to drive us over that NTE, we have to come back.
If I may take this to the second example, we have 32 or 33 contracts for the IDIQ services. And each vendor, in that 32 million, 33 million, whatever the number is, 34 million, those 32 vendors, some vendors they're providing us 10 resources, some vendor is providing us 2 resources, and the vendor providing 10 resources. For example, the contract may be $3 million for 2,000 hours, 20,000 hours, and somebody providing $1 million worth of services has 2 resources or 3 resources for 6,000 hours. So in this example, if that vendor with the $3 million for 20,000 hours, will that come back to the board if that $3 million for the vendor not to exceed becomes $3.5 million?
Yes, saying currently what happens is the finance committee and the board approves each task order. So basically, you don't approve the total amount in a roundabout way. You don't approve the total amount for a vendor. You approve each task order. So out of your case where you have 35 vendors, master contractors, and we have 155 task orders, you're not approving the 35 master contracts. You're approving the 155 task orders. And there's a process in our procurement policies, and I think you were instrumental in bringing that policy, in that if a task order has an NTE amount, then basically we have to come to the finance committee, or if it's timely, we can go directly to the board. So the finance committee gives the approval, and then we go to the board after that. Just like if we have a new task order, let's say we have 156th task order, we have to have an approval process that's laid out in our procurement policies, which goes to the finance committee or the board, depending on the timeliness of it, and is approved for us to go ahead with the new task order.
Okay, and that will stay. And the third example, again, I'm just trying to clarify so that everyone gets a broader perspective. We had a lease for the building, and the lease, I think, was initially 5 years, and then option year after that, a renewal. And I think that was brought back to the board because, the space changes. Something like that, how will that be in the new process? Once the board approves a 10-year lease, even if we change the space we are renting, how will that be affected? Will it not come back to board, or it will still come back to board when the option years come into play?
Yeah, it would still come back to the board. Any change would be a change in the scope of work or the additional rent. So that would have to come back to the board, because that's an increase in the original NTE that the board approved. And then, of course, the second 5-year option, the board has to approve it. But if we were to get more floor space, that would increase the NTE amount, that would necessitate coming back to the board.
Thank you.
So I just have a quick question. I want to get us back on time because we're a little over on this one. Sharon, maybe you can answer. When I read these now, like reading them side by side, there's some finesse in the language, but the proposed process is really the same as the current process, correct, legally?
So I think it would be helpful if Tony moved on to the questions. I think this was meant more to elicit some conversation, which we have had already. But as far as the options, the only difference is whether or not the staff comes to the board for the NTE of the option year, which really, I think what you're pointing out is it's pretty much they're going to come back and they're going to say, this is the NTE that you already approved. can we exercise this option year? So it's really just a difference in how, and saying you're not approving the NTE again, because it's already been approved. So the motion would be something like the board, approves the exercise of the option year at the, already, approved rate of, or NTE of, something like that. And just noting that you don't have to approve the NTE because it has been approved. And all of these are approved subject to available appropriations, which I believe you already mentioned. So if the appropriations aren't available, then of course there would either have to be some other adjustments to the budget or to the NTE.
So I guess, and again, this is Sharon directed at you. I mean, that's what the current process says. And that's the proposed process just removes the NTE language, but you've already said that we would still be assessing the NTE. I'm not sure what's to be gained by the new proposed language versus going with the current process. Like there's subtle changes in the language, but they're essentially the same things, but not exactly the same thing.
So I think the management really just wanted to look at the overall board procurement approval process, and that was a nuance in the option year part of it. I don't think that was really the part that was really requiring extra work for both staff and the board. It's really the base period part of whether each year of the base period had to be brought to the board. I think that's the bigger change.
Ben?
Yeah, I don't know if this is to Tony or to Sharon, but why is the new process better? I'm kind of like, that would be the answer for me. I see we're changing things, but why is it better for the staff or for the board or for the contractor? It just seems like we're just doing it different, which I'm not sure that's a good enough reason to change, but I want to hear what you guys have to say.
I think the main reason is to save time in our meetings, if it's so desired, that every year for a base period, we won't have to come back and request an NTE for that year. So that's the main reason as I see it.
And Ben, I just want to remind you that this actually came from the board, one of the board meetings we had when we were doing some approvals, and the board said, well, why are we seeing this if we already approved, the base period? And so that was led us to go back and reevaluate. And Cynthia, you might want to go to the discussion points because what we try to do is lay out, okay, this is what is being done today. This is a recommended process, but then to put up these questions for the board to have some dialogue about this. And as Sharon mentioned, there has been a lot of good dialogue already.
Okay, so well, I mean, you can read it, but does the board support approving an NTE for the entire length of the contract, including multiple base years and, if applicable, option years? If the board has approved a multi-year base contract and an NTE for the length of contract, does the board want to have a presentation before each year of a multi-year base contract? And the third question is at minimum 60 days prior to contract effective date an appropriate time for the board to review contract recommendation for approval? And for any other thoughts?
Kathleen?
Thanks. Just from my perspective, I agree with you, Laura. It's sort of a nuanced difference between saying we approve the NTE for the entire length of the contract, including multiple base years and option years, versus on an annual basis, we revisit that again. Because to me, what's important is that whenever we make our approval and whatever the scope of that approval is on an annual basis, we will want to hear a report as to whether or not the vendor is satisfying their contract and whether or not the contract should continue, and particularly with respect to option years. And or whether there's a reason to take another approach to either get out of the contract if it's permissible legally, or not to renew it because there are concerns. So I think at the end of each year, whether it's a base year or considering an option year, we're going to be receiving from you a report and your recommendation on how we should continue. And it would be part of that report to have a sense of what the expenditures have been and what reminding us what we've approved and what they should be. So to me, I don't really have a strong preference for whether we say we've approved this subject to future changes, and we won't have to necessarily reapprove the NTE every year, as long as within whatever our process is, we are getting an update on performance. We're getting staff's recommendation on whether to continue or not. And anytime there would be a change in the NTE, obviously that has to come before us. The only other comment I would make is that from my perspective, 60 days prior to a contract effective date may or may not be enough time to look at an option, because if the decision is made not to take an option, not to renew the contract, to me, it's really your judgment as a team, whether you could replace that vendor within that 60-day period, because sometimes you readily can, and sometimes you can't. So I think that that's probably more of a staff call if they're going to be recommending that we not renew a contract, when you need to have that determination so that you can replace the vendor. So those are my thoughts.
Okay.
Thank you. Michelle, can I keep us moving? That this is not something we're voting on. It was just a discussion. I think we've covered many of the, at least certainly 1 and 2, and Kathleen just talked about number 3.
Yeah, absolutely. We can keep moving. And I'll just point out that number 3, as Kathleen stated, is what we're actually doing today with coming back to the board every year with a report, et cetera. But yes, that all we needed was some feedback, and we can go back and draft something up for the board's approval.
Great. Thank you, everyone.
Thank you.
Next on the agenda is Johanna to talk about the 2024 reinsurance parameters.
Hello, can you hear me?
We can.
Great. Okay, great. All right, so happy to be here to present to you today on the 2022 reinsurance results and to request that you vote on final parameters for the 2024 year for the reinsurance program. We can go on to the next slide. So I'll first start off with a quick recap of some high-level information on the 2022 on the reinsurance program in 2022. So that is the most recent year for which we have complete data for the program, which is why I'm providing an update on it. And it's the data from this year that we use to modify our projections and inform our recommendation for the 2024 parameters. So in terms of the program cost, this was a good year in a number of regards for the reinsurance program. We anticipated the program would cost about $520 million when we last did projections last summer. In actuality, it cost about $485 million. So costs came in lower than expected. And from a funding perspective for 2022, we got $344 million. So it's clear that the federal funding did not meet or exceed the cost of the program for 2022. That's okay, because we have a built up balance in state funds. In addition, we have the 1% assessment that brings in approximately $120 to $140 million each year. But for the gap for covering the 2022 cost, we'll be leveraging an unspent balance in federal funds that will cover about half the cost, and then we'll be using state funds to cover the other half of the gap between federal funding and the total cost of the program. In terms of enrollment, this has been consistent since the program started. About 6% of individuals in the individual market qualified for payment under the reinsurance program in 2022, meaning they hit the threshold of the $20,000 in annual claims. And that's a little over 14,000 people altogether. Next slide. And then here's some kind of a snapshot of the claims situation. This again is consistent with what we've seen since the program started. So to kind of orient you to the information on this slide, in 2022, total claims in the individual market were a little under $1.5 billion. Of that amount, the 6% of enrollees who met the threshold for payment in the reinsurance program accounted for 2/3 of claims, and they're represented by the red and the pink in the pie chart. So the reinsurance program reimbursed half their costs, and then insurance companies covered the other half. So that's the two kind of red slices of the pie. And then the 94% of enrollees who didn't meet the threshold for payment accounted for another third of costs in the individual market. So you can see the dark red slice being the amount of reinsurance dollars the program continues to cover about a third of claims in the individual market. So a very significant funding source for the individual market. Next slide. And then just a recap of the impact of the program. I think you're all pretty well familiar with this, but these are some images that we just refresh each year. On the left, you can see a chart showing premium changes in the individual market from 2015 forward. You can see we were looking at double-digit increases in 2015 through 2018. And then in 2019, when the reinsurance program went into effect, we saw premiums decline by double digits for 3 years after starting single digit increases in 2022. This is consistent with what we anticipated. We designed the program to bring down claims by about a third, or about 30%. So it did that over the course of the first 3 years of the program. And then once that was achieved, we anticipated that claims would again increase kind of consistent with average medical trends. So that's what we're seeing with 2024 proposed rate increases coming in at about 5.7% in the individual market. And then enrollment has grown certainly since the program kicked off in 2019. You can see the chart on the right shows we had a pretty precipitous decline in enrollment from 2016 through when the reinsurance program started. And then the market has been growing since then, although we did have a slight decline from 2022 to 2023, not in on-exchange market enrollment that increased a bit, but we saw a bit of a decline in off-exchange market, which drove that overall individual market slight decline, but pretty much flat really between 2022 and 2023. But overall still much higher than we were at in 2018. The next slide, I think, transitions us into talking about the reinsurance parameters. So just a reminder that the board is required to set the payment parameters for the reinsurance program every year for the following year. And there's 4 parameters for the program. There's an attachment point. That's the point at which the reinsurance program starts covering costs for an individual in a year. The coinsurance rate, which is the percent of claims that the program covers, and then the reinsurance cap, which is where we stop covering costs or a portion of costs, and then insurers are again responsible for 100% of the cost. And then fourth, there is a market level dampening factor, which I won't get into great detail here, but in the materials that were shared with the board, there's more discussion about the dampening factor. A quick kind of just summary of it is that the federal government has what's called a risk adjustment program, which helps to mitigate costs for high cost enrollees, as does the reinsurance program, because both programs have that same goal. This dampening factor kind of adjusts reinsurance payments to try to avoid double paying for the same individuals. So the way this application of the dampening factor is structured is that the board determines whether a factor is necessary. And if they decide yes, then the insurance commissioner determines what that factor is. Okay, next slide. So I'll start with the chart at the bottom. You can see that from 2019 through 2022, we had the first three parameters, the attachment point, coinsurance, and cap, were consistent at a $20,000 attachment point, 80% coinsurance, and $250,000 cap, meaning that for any person in the individual market, if they had more than $20,000 of claims, the reinsurance program would cover 80% of the cost of those claims, up to $250,000. And then we had a dampening factor kind of hovering around 0.8, a little lower or higher each year of the program. In 2023, the attachment point was dropped by the board to $18,500. That was our first kind of real change in that parameter since the program started. And then that was always anticipated to be kind of a temporary change. It was decided on in 2023 to help mitigate rate increases that were anticipated in the individual market that year. In 2024, so again, as a reminder, the board sets estimated reinsurance parameters in February each year. The carriers need those to file their rates with the insurance administration in the spring. And then once we get the full data on the prior year, we update our projections and come back to the board now in July with a recommendation and a request that the board set final parameters for the following year, which the insurance administration and the carriers then incorporate as they finalize rates in August and September. So in February, when we had come to the board, we had recommended increasing the attachment point from $18,500 to $19,500, a $1,000 increase. But upon further analysis of our projections and kind of where rate increases came in, and in consultation with the MIA, we're now recommending increasing the attachment point from that $19,500 to $20,000. So we would fully return to where we were in 2022 and prior years for 2024. And then we recommend no changes to the coinsurance rate or cap, and we recommend the board continue to determine that a dampening factor provided by the insurance commissioner is necessary. Next slide. So I'll talk a little bit about what is influencing our 2024 projections that were shared in the board materials and that I'll kind of review here, and then also a little bit more about the rationale for the recommendation to increase the attachment point from $19,500 to $20,000 for 2024. So in terms of what was influencing the 2024 projections, as I mentioned, our actual cost for the program for 2022 was about 6.7% lower than projected, which is great. And then on the flip side, the federal pass-through funding that we get from the federal government to support the program was nearly 8% higher than projected. So in both directions, things broke in our favor most recently. We also incorporated anticipated enrollment changes due to the resumption of Medicaid redeterminations in 2023, the expansion of the young adult subsidy that the board approved at their last meeting for 2024, and then another federal policy change, the fix to the family glitch, which I'm happy to get into more detail if anyone would like. And then lastly, I'll mention that our projections do incorporate the continuation of enhanced federal subsidies through 2025. When we last shared these last July, the federal government hadn't finalized those. So that's new in the projections this time around. Next slide. So in terms of the projected impact of increasing the attachment point by that $500 from $19,500 to $20,000, we don't anticipate an impact on enrollment. So we don't anticipate that that would lead to a decline in enrollment. We do project that that $500 increase would increase average rates in the individual market by about 0.6%. And then kind of the reason for the recommendation is to further bolster the solvency of the program. So that small increase in the attachment point in 2024 is projected to increase our state funds balance by about 32 million. So from about 304 million, we anticipate in our projections up to 336 million. So, you know, still not a huge amount, but I think in the right direction and without anticipating negative impact to the market. We thought that was what we wanted to recommend this month. And the next slide, I think, will walk through what those funding projections are. So I'm going to start with what we were looking at last summer. And well, actually, we updated these in October. So last October. So we anticipated kind of that the board would probably increase the attachment point for 2024. So these October 22 projections include an anticipated attachment point of 19,500. They also assume that the board would increase the attachment point by $1,000 in 2025 and thereafter, kind of on an ongoing basis. However, even with those anticipated attachment point increases, just to, again, orient anyone who's not familiar with this chart to it, although I think you've all seen it before, the bars show that funding that we received to support the reinsurance program, with the state funding from our 1% assessment in blue and the green bar showing federal pass-through funding. The red line shows the cost of the program each year, and the purple line shows our unspent funds at the end of the year. So in the first few years, you can see the red line is substantially below the bars, meaning the cost was less than the funding we were bringing in. That leaves the purple line, our fund balance, to grow over time. However, in 2022, we anticipate that the red line, the cost, would exceed the funding. It's higher than the bars. And there you can see that the purple line, the fund balance, starts to decline, and that's true kind of for each of the out years. The cost is exceeding what we're bringing in each year, and so we're drawing down on that fund balance, which we build up in the early years, which leads us at the end of our new waiver period through 2028 to be kind of just about tapped out on our fund balance. So that was, you know, something that we were definitely keeping an eye on. If we go to the next slide, however, we can see that updating our projections to, given the good news that we got in 2022 with the higher than anticipated federal funding and lower than anticipated costs, if we can, when the actuaries used those new data points to update their projections for out years, we're in a much stronger position. Still one where we need to think about the future of the program, but that purple line is, you know, leaving us with around a $300 million balance at the end of 2028. And again, this is assuming that the board doesn't increase the attachment point to the 20,000 as we're recommending, but I wanted to show this first because it's kind of a direct comparison with the prior slide from last October. And then if we go on to the next slide, and the board increases that attachment point to 20,000, you may have been able to see that the purple line moves up a little incrementally. As I mentioned, our fund balance increases by about that $30,000. So I think kind of my takeaway here, a couple takeaways. These projections assume that the enhanced federal subsidies end at the end of 2025. If those enhanced federal subsidies are continued by the federal government, the reinsurance program will be in a much stronger position. If they do in fact expire at the end of 2025, as is current law, the amount of funding that we're bringing in will not be sufficient in the long term to sustain the program at its current scale. So that will require kind of considering whether the program scales back to stay within funding or additional revenue is needed to support the program. But that's still kind of several years out, and we're certainly all hoping that the federal government will extend those subsidies. But sort of in any case, we're feeling more optimistic about the fiscal future of the program given our most recent data. So I think that's that's it in terms of what I had to present about the program projections and the recommendation, and I'm happy to take questions.
Hey, Johanna, it's Laura. So I guess my only question is, this assumes that the state funding is flat funded. So there's no concerns about fluctuations in the state funding?
No, no. The legislation was passed that authorized the 1% assessment through the end of 2028. So unless the law changes, we'll be bringing that 1%
Okay,
in.
I didn't realize that was in legislation. Okay. Kathleen, then Ben?
Sure, just a couple of things. And, kind of the trajectory of this in the long term is actually part of what we're doing as the, House Bill 413 working group that is Maryland Department of Health, MHBE, MIA, really looking at the long-term plan. And we're doing a lot of modeling of these different variables and, what happens if you add in other sorts of market reform. And our next meeting in August is going to share some of that modeling as we see if there are other tweaks that need to happen. But coming back to just 2024, what I wanted to underscore and remind everybody was that in 2023, we were facing two things. First, the ARPA had not yet been extended, and there was really concern because if ARPA had not been extended, we were looking at 17 to 20% rate increases in the individual market that we're very concerned about. And even with ARPA, the original asks were in the 11 to 12% rate increase. So what we were able to do was claw back 50 million of 100 million that had been allocated to be removed from the reinsurance fund completely. So we put $50 million back in and dropped the attachment point in order to prevent what would have been much higher rate increases than the 6.6%. What that allowed us to do was keep those relatively stable and have, what was still 6.6% is not nothing, but have it be a much smaller increase and do it using money that we would not otherwise have had because it was allocated to go out someplace else. The good news is that the trend numbers that are coming in right now lead to an initial ask of an average 5.7%. Where we start is never where we end. So that 0.6%, I wouldn't in my head add that to 5.7 because I doubt that we will be at a 5.7 by the time my team finishes their actuarial analysis and works with the carriers around what we ultimately approve. But the short of it is that having looked at what the trend is and having looked at the overall, my team felt very, very confident that the attachment point could go back to where it was without having any adverse market impact. And the benefit for that is that we get to keep the $32 million that would have been gone. So I just wanted to remind people a little bit of that context and why we had that 1 year hiccup. And what I think will give us is that it gives us a net gain of $32 million.
Thank you, Joanna. Two questions. The projections don't show, or I assume they assume that ARPA is going to disappear after 2025, or not.
They assume that ARPA disappears after 2025, and you can see from in 2025 to 2026, the funding line drops. That's due to that assumption. If ARPA continues, we actually anticipate that funding will keep pace with the program costs.
And the second question I had is kind of unrelated, but if you look at the percentage of the population that actually hit the $20,000 attachment point, it kind of shows you why insurance works, because 6% of the population had especially high cost, 94% did not. But the question I think I asked before is how many had no insurance cost in a year. I don't know if you've had a chance to look at that. I think that's, a bit of a concern, for any insured population, but particularly, for this population. And then for the 6% that did hit the attachment point, what was the distribution among payers? I suspect, heavily weighted towards Care First, thus the dampening factor, the interplay between risk adjustment, et cetera, et cetera. But just if you have that handy, that'd be helpful.
Yeah, absolutely. I don't have the number percent that had no claims, but we can pull that information and happy to provide it. In terms of the distribution of payers, I have a second portion of my presentation on our carrier accountability reporting, and I think I have a chart in there that may get to that. But you're right, Care First does get the majority of individuals and who hit the attachment point and dollars from the reinsurance program.
Thank you.
Laura?
My question really piggybacks on Ben, and that is, how much do you think the trend that we're seeing is stable and normal again? Based on utilization, and are we really seeing has it stabilized in your from your perspective? Or are we still seeing some runoff from the past 3 years in behavior?
Yeah, it's a great question and a challenging one, because obviously the pandemic just threw a wrench in all kinds of forecasting efforts, because it's such an unusual time. I think so we were heartened that claims were pretty flat from 2021 to 2022, and that's, I think, reflected in the proposed rate increase, which was, not very high, and then is reflected in the fact that the reinsurance costs were less than anticipated. So I think, with limited years of data for the reinsurance program in general, and then coming out of the pandemic, it's a little hard to say, but I think we feel good about it. And I think Brad Bobin from the Insurance Administration is on, and Insurance Commissioner, so if you want to add anything, please feel free.
I think I would just say that Brad and my team clock the trends pretty carefully across markets. And either if Brad wants to, he can give you what he's seeing right now. We're kind of in the middle of breaking down the trends because we don't take anything at face value, right? I mean, the companies lay out what their trends are across different markets, and then we go in and audit that data behind. So we look for their information and why, and then we work with our outside actuaries to validate that information and to see what's happening nationally. So it's a process that we're kind of in the middle of to make sure that we actually agree with those trend factors. He can certainly give you some of the big picture. And also, if it's helpful to the members of the board, we can always work with Michelle to schedule, a primer on, how they evaluate, what they evaluate from a trend perspective, so that you have that educational background. But I'll throw it to Brad if he has anything that he feels he is able to share at this point.
Yeah, I don't have any trend numbers at my fingertips. I will be presenting some at the ACA rate hearing on Wednesday. But yeah, I mean, the individual market trends are definitely down. They're definitely running lower than we're seeing in small group ACA or in the large group market. My team is trying to understand exactly what factors are driving the lower trends in the individual market. But yeah, I mean, when we look at the whole period from 2019 pre-COVID through 2022 to kind of smooth out the big COVID disruption in the middle, we're definitely seeing lower trends in individual than we've been seeing pretty much since the ACA began, and lower than the other market segments. And so yes, the trends right now are looking good in this market.
And I would say, I would add to that probably one of the most important things that Brad just said is he's breaking down the information to understand what's driving those differences, because until we understand what the drivers are, it will be hard for us to answer the question about whether this is a permanent thing. And are we seeing a flat curve? You know, where are, because it responds to the market, right? It responds to the costs in the market. So we will be, as Brad said, we'll be able to share some of that on Wednesday, and I hope you attend the ACA rate hearing that's this coming Wednesday, and ask every question that you have. But we will also work with Michelle about maybe a primer, and maybe appropriately, Michelle, in September after the rates come out, and that will be able to give maybe a little bit better of explanation about how we got there, if that helps.
Yes, and we typically do in the September meeting, ask the MIA to come present on the rates, so that will be perfect timing.
Perhaps a primer before that would be helpful. It sounds like, well, that's just next month, so I don't know. We have enough time, or if we could extend that with the team.
And if you finish up the ACA rate hearings and you have questions, just, irrespective of your role at MHBE, if you have questions, then you just want to have a chat, then just call me.
No worries. I just asked because I'm just curious about the sensitivity of what we're looking at here, like where that graph shifts, and is there something that makes this graph do different things based on that? Right. Thank you.
Johanna, was that your last slide?
I had a few additional slides on our carrier accountability reports, which I can just go through quickly. So just wanted to also share with the board that we require carriers to submit an annual report describing their efforts to manage cost and utilization of enrollees whose claims were reimbursed by the reinsurance program, as well as efforts to contain costs so enrollees don't hit that payment threshold in the first place. We've gotten 3 years of reports so far, and we're in the process of collecting the 2022 reports, and just have some high-level information to share with the board about what we've seen. Next slide. This recaps the type of information we collect at all. Skip over this, but happy to answer any questions on it. But essentially, it's information on both narrative and data on cost and utilization and care management initiatives, as well as some quality information. Next slide. In particular, we collect targeted information on 4 conditions that are the topic of state population health work, which are diabetes, behavioral health, both mental and behavioral, asthma, and then pregnancy and childbirth. Next slide. So I think this gets at Ben's prior question related to enrollment and payment under the reinsurance program by carrier. This doesn't have the 2022 data, but you can see the number of enrollees with claims reimbursed by the reinsurance program, payments, and kind of percentage breakdowns, and how that compares to the carrier's percent of total market enrollment. And we have CareFirst data broken out by the HMO and PPO. So you can see that CareFirst collectively tends to account for about 80% of enrollees with claims reimbursed by the reinsurance program, and then kind of a generally similar percent of the payments under the program. Next slide. In terms of the care management initiative, so we request, again, both narrative information on care management activities for these 4 conditions, and then also some data information. No carriers had care management initiatives targeted towards asthma and pregnancy. CareFirst and Kaiser both had care management initiatives focused on behavioral health and diabetes. United was new to the market in 2021, so they do have a behavioral health program, care management, and a kind of generalized high-risk case management program. But we require that the care management initiatives have at least 300 enrollees in the individual market to be reportable, and given their relatively small enrollment in 2021, they did not meet that threshold. Next slide. And then here's some data on the most frequent conditions among individuals who had claims reimbursed under the reinsurance program. And the next slide will have data on the most costly conditions. So in terms of most frequent, you can see diabetes is sort of the same three conditions were in the top three and swapped places a bit depending on year, but they were cancer, HIV, AIDS, and diabetes were the top three most frequent. And then we also saw the fourth and fifth slot shift around a little bit, but you can see those elements there. And that blue highlighting indicates that those were conditions that we were collecting the targeted information on. If we switch to the next slide and look at the most costly conditions, we again see diabetes in the top two in the first couple years, cancer holding the top spot in all 3 years, sepsis in the top 5 and coming in at number 2 for 2020 and 2021, and then a little shifting kind of again and below that with respiratory arrest, heart failure, ESRD, hemophilia, all kind of showing up in these top 5. So in terms of, what we're doing with this information and why we're collecting it, we're evaluating whether in future years we want to shift those targeted conditions that we're collecting data on to perhaps more closely align with some of these higher cost conditions, although we're particularly, interested in conditions where there are potentially preventable costs, which doesn't always, is not every condition. And then also using these reports as a springboard for more in-depth conversations with the carriers about their care management efforts. So those are kind of ongoing efforts. Over the first few years of doing this, we've kind of been refining the data collection, trying to better understand how to ask for and what to ask for in this data. But we are looking to kind of switch gears and transition into more active conversations with carriers about this information. And I think that's my last slide on this topic before just asking for the motion to approve the 2024 parameters, but happy to also take any questions on the carrier accountability report.
Thank you, Johanna. Any last questions before I propose the motion? Okay, I move to approve the final parameters for the 2024 state reinsurance program as follows: an attachment point of 20,000, a coinsurance rate of 80%, a cap of 250,000, and a dampening factor to be provided by the insurance commissioner as presented. Can I get a second?
Second.
Any other discussion? Those in favor?
Aye.
Any opposed? Okay, motion carries. Thank you, Johanna. Next on the agenda is Tracy and Venkat to talk about Amazon Web Services contract FY24 not to exceed increase.
Thank you, Madam Chair. Good afternoon, Madam Chair and members of the board. Today, I'm joined by our procurement officer, Tracy Gamble, in requesting the board.
I'm sorry, actually Tracy has COVID, so basically I'm stepping in for her.
I'm sorry to hear. Thank you, Tony. Today, I'm joined by our CFO, Tony Armiger, in requesting the board to increase not to exceed amount of our contract on the AWS platform, the Amazon Web Services platform. I will provide some details on what this platform is and why we need to go in this direction and how it aligns with our strategy, and then what we are actually asking for in terms of NTE increase. Actually, the NTE increase is not a request for additional funding, it's just a reallocation of funding in this particular case. So the critical role of Amazon Web Services AWS in our operations and how we can make it even better in alignment with our strategic priorities, obviously the board support is very important for the agency. As a high-performing agency, we have always been dedicated to leveraging technology to drive operational efficiency and innovation, and continuously build resiliency over the years. And as you know, we are using the AWS platform in several important areas within MHBE, in addition to the MD Think AWS platform. This is a separate platform. This includes our stakeholder website, MHBE.com, our Mellon Health Connection for small business. I know it's small right now, but we have a strategic plan for building an end-to-end platform and also the services around it. And the highly successful Broker Connect platform, our live agent chat platform, and our internal WordPress site, affectionately called as Beehive by our marketing team. And our recently implemented enrollment dashboard via Tableau, as Michelle noted in the Executive Director's update, and also our robotic process automation operations. As you can see, there are several things are already being posted on this platform, which started very small. In fact, if I recall correctly, less than $10,000 a month operation was started a while ago. Moving forward, we have identified 3 key strategic areas where we are going to ramp up our use of AWS, which will increase the costs, obviously. But when you consider these costs against the benefits and again, in alignment to the strategy, I think we would appreciate it's really cost effective, but puts our agency on a track where technology powers our innovation and supporting our operations. So number one is, as noted here, building out our disaster recovery capability and business continuity capability. Currently, we have something which is basically an extension, a little bit of extension of MD Think platform, some additional subscription of services that would power up if MD Think goes down. But for our agency, with so many things on MD Think platform, that is not sufficient. And I did present to the board last year, and we did seek CMS permission, and thankfully board and CMS supported the effort. And unfortunately, due to a variety of reasons, in the last year, we could not proceed at the speed at which we wanted to. And thanks to the new administration and for the tremendous support that we are getting at this time. And the second initiative is migrating the lower tier systems. We have 11 system environments, out of which we plan to migrate 9 out of MD Think into this AWS mainly to align our technology and build a proof of concept environment, and also to realize some cost efficiencies in this as well. I will provide some more details as we go along this presentation. And the third is our continuous enhancement of our systems, extending the reach of our technology footprint to utilize more cutting edge modern technologies for our operations. So these are the 3 areas. And the next slide, please. As I noted, these steps are crucial as we want to enhance technology benefits in alignment with our strategy and industry trends, and keep providing top-notch services to our stakeholders. But to make all of this happen, obviously, we will need an increased allocation for AWS platform. So as the first step, the disaster recovery build out, our goal here is to boost MHBE's DR capability by establishing an alternate DR option outside of MD Think. You can't have a disaster recovery having everything at the same place and hope that the disaster recovery will also work. So that is not the industry trend. It's not the industry standard. So building separate on our AWS platform will ensure uninterrupted business operations in the event of unfortunate primary system failure, causing specifically inaccessibility for our consumers to critical resources through our websites and mobile applications. So that's our core goal. We have, as I indicated to the board, presented to the board a few times earlier last year, we are doing it in multiple phases. In the phase 1, we wanted to have a disaster recovery site built for consumer specific applications, and then phase 2 will be a more robust connecting all the applications. And we have been working on this, and we do require support from MD Things, which thankfully, again, in a positive light, after this new administration, we are getting it. We are working closely with MD Think team as well on this. That's about disaster recovery. And next slide, please. Thank you. The second one, our aim is to migrate the HPX lower tier environments, hopefully 9 environments in total, and also set up a proof of concept environment on our AWS platform. This will expedite a lot of our required system work and facilitate our strategic directions on implementing innovative solutions with better speed and less overhead. Actually, we have a great team and we don't need additional resources. And we just need to align the resources and the technology and our services. And also by completing this migration, creating a proof of concept or a sandbox environment, we can improve several technology options such as code deployments, reducing environment downtime in terms of development environments, and also enhancing security for our lower tiers, and also becoming more responsive to our release needs. Unfortunately, that is currently lagging. And also we hope to save costs in reducing server footprint and professional service expenses, which I will detail in subsequent slides. The next slide, please. Yeah. So in terms of expanding, the third critical strategic direction is expanding the MHBE enterprise footprint. Within this, we have listed some 6 core category items. There are a lot more. I just tried to, in terms of time, I want to condense it, and I'll be very happy to answer questions or provide further details for the board. The first one is obviously the Mail and Health connection for small business. That's one of our strategic direction from the policy, and we intend to create an end-to-end enrollment portal for small businesses on website and also on mobile app. We do have a minimal presence right now, but as we expand and integrate with carriers and third-party administrators, this is going to be a robust platform for small businesses. And we are intending to host it on MHBE AWS for a variety of reasons, as this technology is a little more superior compared to other AWS that we have. And also, this is going to integrate with our other technology functions on AWS. So that's our first priority. And the second, we noted here as shared services. What it means is we are doing something called continuous integration and development. What it means is we would be able to, currently our release cycle is pretty short, meaning every month we have a large release and every week we have something, and if we need something on a daily basis, we can do that too. Thankfully, our policy and technology aligns very well, and that's why we are able to do this. And the next step is doing more integration and development, which is, you don't need a month to wait for something to go live. That's the concept. So you have a pipeline, you constantly build, your policy changes, system changes, and you constantly implement as per your priority. So we are moving towards that direction. And I have mentioned a few tools here. All these tools, when combined, potentially give a robust infrastructure for CI/CD capability and code quality assurance and application security testing and log monitoring. All of these are very vital for maintaining high quality software development standards and practices. The next slide, please. Thank you. So by building these services and enterprise assets into AWS, what we intend to do is to reduce the physical footprint of our on-premise service. I understood we had an issue when one of our server room temperature went up, so we had to do an emergency procurement to buy some cooler to cool it down. And these kind of dependencies on on-premise servers is a problem. And as the technology moves more towards cloud, we need to improve the reliability and performance of critical services such as VPN and our internet services, and keep the exchange staff function better, and also the systems more operational. And also the scalability and flexibility of AWS will enable us to quickly respond to a variety of changing needs and also ensure the continuity of quality of our services. So this is something internal. There are some software mentioned here, and this will also be part of the enhancement of AWS services. Next one, please. One. I think one before. Yeah, one more. Yeah, this is good. Yeah, sorry. So on the.
I think
the
you
next one,
need to
I'm sorry.
advance.
Yeah, thank you. That's good. I'm sorry. The API gateway, what we noted here is API gateway is something that manages and protects our server-to-server interactions. As we introduce more and more new services at MHBE in terms of technology, we are basically expanding the role of our API gateway to handle more and diverse connections. This is not just adding capacity, but also enhancing security. By improving how our gateway protects our so-called API endpoints, basically what we are doing is we are hardening our defenses against potential threats. So this expansion is about increasing service integration scalability and also fortifying our security, all of which are vital for continuous services in a technology-centric organization. The next one, please. Thank you. And we, as the board knows, we have been using the RPA, the robotic process automation technology. 30% of our consumer documents are now validated by our bot automatically. And we also introduced artificial intelligence technologies in terms of responding to consumer queries and through chat. We are currently working on those, improvising those technologies, mainly to provide more excellence in system operations, and also in consumer engagement. By integrating RPA into our system operations, we proved that we could automate repetitive and labor-intensive tasks, and we want to expand it further in terms of technology, also in terms of monitoring our databases, monitoring our certificates, and periodic health checks, etc. And these automations free up our staff resources, and we can focus more on critical and strategic tasks rather than repetitive tasks. And leveraging AI technologies is a very critical thing. I'm sure you are aware of a lot of natural language processing technologies evolving. We are working on some proof of concept, and I'll be very happy to provide our progress in the subsequent board meetings on this as well. Next slide, please. And lastly, data is everything. And as we begin to know, and we will be modernizing our data management business intelligence platform by building something called a data lakehouse. It's a fancy term, but it's basically an open approach to data that combines the best elements of a variety of data technologies like data warehouses and data lakes. It's designed to handle both structured and unstructured data, making it possible to perform different types of analytics down the line. Again, these infrastructure have to be built early on, and so that we can build dashboards and reports, and that can do big data analytics and real-time analytics and variety of other analysis of data that can help MHBE move towards more advanced capabilities that can throw insight into data that can ultimately help with our policies and our consumers and to make informed decisions in many ways. So in practical terms, what we might use down the line, more AI and machine language technologies to do predictive analytics in some ways. And also we can also identify some common issues faced by consumers when they go through our website, and also potentially address problems before even the consumers escalate to our call center. So these are some of larger ideas. In order for us to build, we need to build the capability for infrastructure capability for those initiatives as well. And before I get into the cost side of it, to sum up, as part of our IT strategy, we are seeking basically to increase our AWS usage, and obviously it increases associated costs, but it would bolster our disaster recovery capabilities, enable efficient migration of lower tier environments and operations of those environments, and also amplify MHBE's enterprise footprint. So we are investing in high-tech tools and migrating vital services to enhance security, performance, and operational efficiency. But our focus is always on providing the continuous support, operational support for our consumers, and using these technology, leveraging this technology to provide better services to our consumers. This is on the technology side. On the cost side, so I would request the procurement officer to give details, but I'll give a very quick overview of the cost. We are anticipating a total cost per year on this platform would be around $2 million in total. And however, we think that we can realize some efficiencies around our current programs. For example, we anticipate to save approximately 60 to 65,000 a month in MD Think AWS platform costs once we move the lower environments to the MHBE platform. That would yield approximately $750,000. And also similar amount in professional support services can be achieved as well, because 70% of MD Think's work for us is on the lower environment. And so both add around $1.5 million in total that could be realized within the IT program efficiencies. We don't need additional funding beyond that. The remaining 500 to 600,000 may need an additional potentially $100,000 to $200,000 in state funds down the line. But I think in FY24, this additional amount also can be addressed within the existing IT budget. So bottom line, what we are requesting the board is to approve the increase in usage of AWS platform for these initiatives while identifying saving within our existing program. And thankfully, I want to add that also we did in our presentation to the CMS requesting funds for the next federal fiscal year. We did talk about some of these initiatives, and we got approved the federal side of the funding as well. With that, I will stop and pause for questions before handing it over to Tracy.
Okay, but
I'm sorry, Tony.
Any questions for Venkat?
So, yeah, Venkat, I'm kind of lost on the interplay between things we are paying for and a functionality that is embedded in MD Think. That may be kind of a innocent question, but can you delineate that a little bit?
Sure. Thank you, Ben. The production system and the stage environment that are currently hosted on MD Think platform for the HPX core application, that's going to continue to be on MD Think platform. So we are not touching that. But besides that particular application, which is obviously our core application, there are numerous other applications we have already built over the years on MHBE's AWS platform. So what we are seeking now as strategic direction is to migrate the lower environments from MD Think to this platform, because we don't really see the efficiencies being made on the MD Think platform there on the lower environments. When I say lower environment, these are the environments that cater to the development, the testing of applications, the training environments and such, not the stage environment, not the production environments. And in addition to these, we are building a variety of capabilities on the MHBE's AWS platform itself to support our data analytics capability that is not connected to the MD Think platform at all, and support our live chat, for example, our small business platform, for example. All of these are outside of MD Think platform. So all we would be doing, in addition to building capabilities here infrastructure-wise, one additional thing we would be doing is building a disaster recovery capability, which is outside of MD Think platform, which is not there currently, and also migrating some 9 or so environments into MHBE's lower environment tier. So that's the only difference. Still afterwards, MD Think will be there supporting our stage environment, 2 stage environments and production environments. There will be a couple of lower tier environments to help the promotional path to production also. That is still going to be there. But we think by realigning some of these technology stacks between MD Thing and MHBE and adjusting the cost within the existing program, we would be able to achieve a lot more than what we are currently doing and getting services from MD Thing at this time. I hope I answered. If not, I will quick answer.
Helpful, thank you.
Okay. Ready to go to the next slide for procurement? Okay, this is not a procurement per se. This contract was procured in earlier, last year, probably September, October timeframe. The contract was signed. Basically, we brought it before the board. The 2 base years of the existing contract the contract started November 1, 2022, and the base period ends in October 31, 2024. There's also one option year from November 1, 2024 till October 31, 2025. The procurement method that was used was a request for quote, RFQ through GSA Schedule 70. The cost of the license, NTE, that not to exceed for November 2022 to June 2023 was $285,000. The projected cost of the license, the not to exceed for FY 2024, as Venkat said, is $2 million. The annual cost, it varies based on utilization. The board approval for a not to exceed amount will be requested for each fiscal year. And the vendor is A&T Systems, Inc. Okay, go ahead. Next. Okay, the split between this is the federal, the $2 million, $1.32 million is going to be federal. And as Venkat said, that was already approved by CMS. And $680,000 is going to be borne by the state. So, and then the next slide. So I know board, Laura, would you like to read it, or would you like me to read it? I mean, I'm not sure how you would like me to proceed.
Sure, I can make the motion based on what the request listed on the page here is. I move that the board I move to approve MHBE's requests for the board to approve the FY24 and NTE amount of $2 million with a federal participation amount of $1.32000 million and state participation amount of $680,000 to the vendor A&T Systems as presented. Can I get a second?
Second, this is Ben.
Thank you, Ben. Is there any more discussion? All in favor?
Aye.
Aye.
Any opposed? Okay, motion carries.
Thank you.
Thank you.
Next on the agenda is Scott Brennan to do the annual compliance report. Michelle, I do have a hard stop at 4 o'clock. We ran way over, so I'm just letting you know. Ben, go ahead.
Oh, Ben will continue on.
Ben, I was just going to ask if you
Okay.
continue on when I drop at 4.
Yes.
Okay, thank you.
And we should probably see if anyone else has to drop at 4 to make sure we have a quorum. Can the rest of the board stay on beyond 4 p.m.?
And will that be to start the executive session at the closed session at 4 p.m.? Or will that be, because I do need to stop around 4:15 or so.
Okay, and Sharon, I had sent you an email. As I recall, the closed session is an update. Is that something that can be pended and not done today?
Yes, Michelle, I did respond to your email,
Okay.
but it's up to the board. There was an update. There's no action that was required. It will probably require a special meeting before September. And also, I probably will not be at the September meeting. There'll be another attorney here, so it'll probably have to happen before the September meeting.
If it won't take too long, if maybe this session can stop around 4. And if
Okay.
15 minutes is enough, we can maybe do the other session right after this.
Okay, that works. Scott, take it away.
All right, I'll try to move expeditiously in the interest of time. This presentation represents the Compliance Department annual report to the board. It's comprised of 4 parts, the first of which is the Department of Justice Effective Compliance Program Self-Assessment. This is a recap of FY 2022 reporting. However, it does project a lot of the prerogatives that compliance seeks to implement in the future. Second point is board oversight of compliance and privacy. The third point is fraud, waste, and abuse reporting. And then we finish with privacy policies, external audit corrective actions, as well as internal reviews. Next slide, please. All right. This is the DOJ self-assessment. Next slide. When we look at the self-assessment of our compliance program, we base it on 3 criteria, 3 overarching criteria. And the first is the compliance program well designed? This takes into account risk management, policies and procedures, regular training and communications, confidential reporting structure, and third-party management. Second element is the program being applied earnestly and in good faith. This takes into account the commitment of senior and middle management, autonomy and resources, and appropriate incentives and disciplinary measures. And the third principle that we look at is, does the compliance program work in practice? Is there continuous improvement within the program? Is there proper investigation of misconduct? And is there analysis and remediation of any underlying misconduct? Next slide, please. So some of the strengths and suggested improvements are listed here with regard to whether the compliance program is well designed. Some of the strengths that were found in the self-assessment were that criticality model exists to prioritize review of high frequency, high risk items, that there is interdepartment collaboration in the policy and procedure development, annual audit plan process, which addresses internal reviews, and ongoing governmental oversight activities, MHBE oversight of consumer-facing programs. And suggested improvements include potentially having a third-party assessment of our compliance program based on the DOJ standards. We want to evaluate risk management models going forward, as well as using surveys to assess internal stakeholders and third-party vendor perceptions. We want to improve coordination between HR, procurement, and compliance departments on code of conduct violations as and when appropriate. We want to provide additional modes of communication to anonymously report allegations or concerns. And we want to increase our auditing of third-party vendors. Next slide, please. Now, when looking at whether the program applies earnestly and in good faith, some of the strengths were found that our internal investigations were found to be transparent and collaborative. The communication with leaders was bolstered by quarterly risk management meetings. Compliance leadership was supported by audit and privacy managers, and the ability to create tailored audit plans and report outcomes to the board. Areas for improvement were noted to be evaluating whether to include compliance and ethic behaviors to all employees' job descriptions and performance metrics, to adopt an acceptable risk tolerance posture, implement evidence-based compliance initiatives to foster accountability, and also create board and compliance leadership communication mechanisms. Next slide, please. And the third and final metric for consideration was, does the program work in practice? Some of the strengths were found to be that there exists an iterative auditing process, a normalization of corrective actions, improved internal controls, and a commitment to improve the culture of compliance, which takes into account accountability and ethics. Suggested improvements were our coordination between HR and compliance on any violations of misconduct, again, if and when that's appropriate. Improve contract monitoring process, improve root cause analyses, investigations, and documentation of incidents, and increase communication with and feedback from direct line staff, consultants, and third-party vendors. Next slide, please. All right. This next section covers board oversight of the Office of Compliance. It's important that there is a direct access capability from compliance to the board. And this is accomplished by regularly reporting to the board and by establishing an open line of communication. And we are working on a policy to effectuate these highlights below. We propose that the Director of Compliance and Privacy can report directly to the Audit and Finance Committee Chair, that there's an established protocol for escalation of significant compliance events, and that reporting is capable from the Director of Compliance and Privacy directly to the board. The frequency of that reporting is important as well, and proposed to be on a quarterly basis from the Director of Compliance and Privacy to the Finance and Audit Committee, with annual reporting to the full board, and ad hoc reporting to the Chair of the Finance and Audit Committee when appropriate. And this is all done with the focus on maintaining the independence of compliance leadership to manage MHBE's compliance and ethics functions and establish autonomy from management as necessary. So again, look for a policy to encapsulate all of these prerogatives in the near future. Next slide, please. All right, now we move on to our fraud, waste, and abuse reporting. This is actually a representation of our hotline reporting. We had 6 fraud, waste, and abuse allegations that were reported via the hotline. 2 were substantiated and forwarded to MDH for investigation. This would happen if the purview of the subject matter and whether MDH would be best suited to conduct and complete the investigation was determined from MHBE. So again, we had 2 substantiated and forwarded for investigation by MDH. 1 was unfounded by MHBE, but also forwarded to MDH. And then 3 others were unfounded and closed. With regard to our debarment and sanction screening, we ran all necessary parties through the Health and Human Services Office of Attorney General, list of excluded individuals and entities, finding that all were clear of exclude. No one was on the excluded list. This included 96 IQ master contractors, 49 vendors, 4 carriers, and 63 MHBE employees at the time the report was run in June. Next slide, please. This next section is the final reporting on privacy, and these are the current privacy prerogatives and year-over-year data. With regard to our privacy overview, we have 110 IDIQ master contractor non-exchange entity agreements, which are all executed and were executed timely. We have our Snap Data MOU has been executed. Our ongoing agreements include those with the Comptroller of Maryland MOU, as well as our ServiceNow non-exchange entity agreement. Our assessments were recently completed and submitted timely. These include the privacy impact assessment and the MARS-E self-assessment and privacy attestation. Currently underway in our privacy program is the privacy incident management system, which is currently in phase 2. Our phase 3 is currently undergoing development, and we are currently implementing annual trainings and attestations as required, and expanding those trainings and reforming them to make them more efficient, effective, and responsive to risk areas that we've identified. Looking down at the number of incidents, we have seen a downward trend this year compared to last, with total incidents dropping from 170 to 140. Our total number of misloads, which are part of that greater data set, have dropped from 85 to 80, and our number of customer service representative errors have dropped from 7 to 5. While I'd like to say I could pinpoint the exact reasons for these drops, I can't provide a causative explanation, but I can and will attribute it to improvement of processes across our privacy program, as well as increased and more pervasive training across the board including with our vendors. So it's encouraging to see this, especially in light of the unwinding that has been going on. So we're encouraged by these numbers. Some are more statistically significant than others, but in any case, an across the board drop is always encouraging. Next slide, please. This policy and procedure update, I'm not going to go through all of the policies we currently have, but we do have a handle on the policies and procedures, which we have an interest in keeping up to date. We have one that was updated during FY23, which is suspension of producer authorizations. We do have 3 currently in progress, one of which was referenced to board oversight and reporting. That's the Chief Compliance Officer policy there that you see under review. And then the final policies just represent those slated for review and update through the end of this calendar year, just for presentation purposes. Next slide, please. All right. The external audit timeline. This is a summary of current and past external audits. The first of which is the EIPM pilot. This is complete because CMS decided to conclude this earlier than expected, but we were actively participating in that up until the point that it was concluded. We have the MDH PERM audit, which is in progress. Our DBM Red audit was completed, as well as our IRS corrective action plan under the system security report. And then we move on to our independent external audit from CMS. There's the financial audit and the programmatic audit, both of which were completed and submitted timely. That also is under the purview of the SMART audit underneath that. And then perhaps most relevant to report is our Office of Legislative Audits. Triennial audit has started as of June 28th. So we have our auditors on site. There's an IT component to that and a programmatic financial component, if you want to break it down that way. So they are in regular contact with us, and that is a high priority, high intensity task for the foreseeable future for not only compliance and privacy, but across our agency, particularly with procurement and Tony's team under the CFO. So we are working to cooperate fully with OLA, and we have gotten off to a good start in providing and being responsive to their requests, and we can intend to continue to facilitate their audit. It is foreseen that it will go through the end of this calendar year. There is some variability in that projection, and again, that's up to the discretion of OLA. So more reporting to come on this topic. Next slide, please. All right. Our year-to-date audit status report. We had 2 DBM red audit. We had our red audit, and then we had audit findings as part of our independent external audit. Those are currently under corrective action plan, and we are working to timely effectuate that by July, which is our deadline, and we are on track to meet that. Additionally, we have the MDH payment error rate measurement, the perm audit, which we're working to through any findings and investigation of that. The next topics are JIRA tickets, and these are in response to not only audit findings, but also internal reviews. And these represent our internal process for identifying and correcting aberrations in our system, whether it's a process or business rule failure or something that is not working right within our system. And so recorded here are some of those aberrations that are undergoing correction. In the event of failure, it would be correction. And some of the other ones require some other scrutiny if it's not a business systems operation failure. So we have a handle on what is not working. We have a process to work through it and create corrective action programs and implement them as necessary. Next slide, please. All right, our internal reviews have all been performed. We have a total of 6 of them. They were performed in areas of HR and organizational effectiveness, our IDIQ program, our CSC fulfillment contract monitoring, appeals and grievances, marketing and communications, as well as policy and plan management. Most recent were concluded just last month, so we're happy to report that all of these were done in the last fiscal year. And we intend to continue this process into the future, and we find it a very effective way to do a self-assessment and consistently improve, and also identify risk areas as well. Next slide, please. All right, that concludes our annual report. And pardon me for trying to go through that fairly quickly, but I'm happy to answer and address any questions or comments from the board.
Thank you, Scott. I'm assuming that Dr. Herrera Scott has left. Is that right, Michelle?
Yes, she did leave. And Ben, we have 3 others that have to leave. Singh and Dr. Allen and Commissioner Bahrain will all have to leave by 4 between, about 4:10 for all of them. So I don't know if the board would like to continue with the closed board session. There still is a quorum of 5, or just to, we could reschedule it another time. That's the board's desire.
Well, we aren't voting on anything, are we? So technically, do we need a forum?
We don't need a quorum because there's no vote, but
Well, there's a vote to go into closed session, so we will
Gotcha.
need that vote.
I prefer, since there are 3 people, all who contribute quite a bit to the board, that we just maybe reschedule so we can have longer period of time to have discussions and have their input. But I would be willing to stay if that's what the rest of the board wants.
other comments?
I mean, I can stay until 4:30 because that's what I have on my calendar. It's 4:11 now, but I can't go beyond the calendar period that I had targeted, which is ending at 4:30.
Yeah, I'm in the same situation that I have to be.
I have maybe another 5-7 minutes at the most, so I can start the session, be there for the initial part, and then leave.
Sharon,
Let me just state that I don't think it will be helpful if we don't have at least a majority of the board present. And this was actually more for board members who aren't familiar with the matter. So it's very helpful if they are present as well. And I had about a half hour scheduled for presentation and discussion. So I think it should be rescheduled for a special meeting that that more board members can attend.
I think that's, sounds like it's agreeable to most everyone.
That
Yes,
sounds reasonable.
So I'll have Cynthia work with everyone's scheduling to get that meeting scheduled. And then I guess you can entertain a motion to close the meeting.
I am entertaining that. Do I have a motion?
so moved.
Second,
Sure.
I just want to clarify, this is to adjourn the meeting, not to close the meeting.
this is to adjourn the meeting.
Yes.
All right, so we have our motions. Thank you, everyone, and thank you to the staff. Great presentations. It's a lot of work to put on these productions, and we really appreciate everything the staff does. They go off flawlessly, and it's noted by the board members that everyone's well prepared. So thank you all. I did have one observation that I think before Dr. Herrera Scott left, I wish I had made, which is I'm alarmed. Septicemia is in hospitals. It is typically one of the 3 or 4 highest ranking DRGs that comes up. But I would be curious as to if there are any initiatives on the part of the payers to address it, because often septicemia or sepsis are avoidable. But once a patient is stricken with it, it's very expensive.
Yeah, I mean, I think that's always interesting to see what role the payor plays in health care, which is something that at least I, as the insurance commissioner, try to avoid, is having payors get overly involved in health care. And obviously the Medicaid world can be a little bit different with the MCOs and sort of what Medicaid controls. But I always think that it's useful to understand what it is outside of the hospital setting where payors don't really actually have any control. What would, how overarching the incentives are around, those things that outside of hospitals, carriers can include in their value-based payment parameters. But I think at some time it might make sense to have a conversation about how much we really not only expect, but we actually want health insurance companies to be doing to drive the kinds of care decisions that impact outcomes. Not that they are completely without some tools and a value-based care kind of, which is a contract thing that literally just became permissible under Maryland law from an insurance company perspective. But I think it's a good conversation to have. I just always jump up right away because as a commissioner, I spent a lot of time telling insurance companies not to tell doctors what to do. So, from a coverage perspective and a medical necessity perspective, and I always want to be really thoughtful about that line.
Thank you for those
Yeah.
comments. Very well. Well, listen, I think the meeting is concluded. Thank you all.
Thank you.
Cynthia will be back in touch on when we'll have our closed session briefing. Bye now.
Bye.